Okay, you should see the banner come up momentarily. There you go.
So welcome and good morning to everyone. Thank you for joining our quarterly Nursing Home Financial Advisory Committee meeting. You should have all just heard the automated announcement that this meeting is being recorded. Per Governor Lamont's Executive Order 7B, all public meetings must be recorded or transcribed and made available to the public. Therefore, in order to ensure a quality recording, we ask that everyone please mute their phones at this time and remain muted unless wishing to speak. Also, to assist in making the recording clear, please announce your name each time you begin to speak. Melissa, I'll go ahead and start the roll call.
Great, thank you.
So Kate and I are here. Nicole Godburn is here. Matt Barrett. Judy Dowd.
I'm here.
Hi, Judy. Good morning, Mag. I see Mag Morelli. Maraith Painter. Maraith is here. Good morning, Maraith.
Good morning.
Michael Morris from Chifa. Are you able to join us this morning? We have a few people who have called in.
Michael's going to be, is excused for this meeting, Barbara.
And Claudio Galtieri from OPM. Were you able to join us, Claudio? I'll move on to legislators. Senator Moore, are you able to join us this morning? Representative Abercrombie. Senator Berthel. Representative Case. Senator Doherty Abrams. Representative Steinberg. Senator Summers. Senator Wang. Representative Pettit. Senator Austin. Representative Walker. Senator Minor. Representative France. And our distinguished guests, I don't know if they're on the line, but let me solicit that. Commissioner Gifford. And Deputy Commissioner Aaron. And if there are others that I have not announced, could you please introduce yourself? And I will start out with Jonathan Fink, who is on my screen, left lower level.
Good morning, Jonathan Fink here on behalf of Leading Age Connecticut.
And David Lawler, could you please introduce yourself? Thank you for joining us.
Good morning, Barbara. Dave Lawler with Leading Age Connecticut United Methodist Homes.
Larry Santilli, I think I heard that you were able to join us.
Yes, I am. Sorry about that. Larry Santilli here.
Sue Eccleston, could you please introduce yourself?
Yep, Sue Eccleston from OPM. Thank you.
Hillary.
Hi, Hillary Felton-Reed from Robinson & Cole, representing Leading Age Connecticut. And I'll also just say I received a text message from Ken Prisby that he's trying to get in. I don't know if anyone has noticed that, but just trying to help him out. If not, maybe he has the wrong link. So
Yeah, he's definitely using the wrong link because he's not in our waiting room.
Okay, I'll tell him. Thanks.
Thank you, Hillary. Nick, could you please introduce yourself?
Hi, this is Nick Mazzato with Department of Social Services Reimbursement and Certificate of Need.
Next, Emily Shepard, please.
Hi, Emily Shepard, OFA.
And then I have some call-ins, so if you wouldn't mind if I announce your number. The area code is 781.
Good morning. This is Betsy Boyvid with Reimbursement and CON at DSS.
Good morning, Betsy. Next is 860-751-3900.
Hi, Barbara. That's Mike Mosier from Athena.
Good morning, Mike.
Morning.
Next is 860-751. Oh, I'm sorry. It's a repeat. Is that you, Larry?
Yes, it is.
Okay. Is there anyone that I may have missed? So as a reminder, if you are going to speak, because the call is being recorded, could you please announce yourself for the record? And if people are joining in late, I will perhaps call out on them to just introduce themselves. And again, remind them to announce themselves when they are speaking. So, Melissa, I think I've taken care of all of the housekeeping issues.
Yep. Yes, we're all set, Barbara.
Okay, thank you, Melissa. And again, thank you everyone for joining us. It feels good to get back into the swing and how we're going to start normalizing some of our activities and the opportunity to talk about things broader than COVID. I know myself, I've certainly embraced. It's telling me that the pandemic is starting to come into our rearview mirror, which I am happy to celebrate. So having said that, after we've done introductions, our first agenda item is the COVID-19 response update. Kate, do you want to go first, or?
I would actually love to defer to you and Maurice. So Maurice, would you like to start us off?
Sure. Good morning, everybody. So our teams are actively back in the long-term care communities. Our volunteers are also back in, and I will say we've had a surprising response to our call for volunteers. So if you want to let your buildings know, they may have a volunteer joining them soon that we're very excited about. We've been doing a lot of training over the past couple of weeks, and they'll start to see that in our long-term care communities. As we're responding to sort of what we're seeing as we're going back in, one of the biggest challenges that we're hearing at this point is related to staffing. You know, the long-term care communities are talking about their ability to access staffing and then the accountability related to staffing, because staff know that they can go somewhere else. And so that's been a bit of a challenge in being able to hold people accountable when there's an issue or a concern, that they don't just leave and then go somewhere else. And so we're hearing from DNSs that when we're bringing up issues and concerns, that yes, they want to hold accountable, but then they're worried about also having enough staffing. So maybe that's something we can problem solve around, because I do understand that pinch point and how that can be extremely challenging, but we also want to make sure that residents' rights and dignity and respect are all at the forefront of how individuals are experiencing their time in the communities. And it's not that I don't think the buildings are doing that, but I do think they're struggling with the balance of that accountability. One of the things that we've also heard is because of the staffing challenges and the amount of agency staff being used in some communities because of this, residents aren't necessarily feeling that individuals know their care or by the time they're able to get to them, it does take a long time because they're having to walk them through or talk to them about how they want their care done. This would happen on occasion before, but we're hearing it's happening more often, again, because of these staffing issues. One of the things that we're encouraging residents to do, and the industry might hear our staff, my team members asking, is to look at the care card. So we're really encouraging residents to make sure that their care cards are up to date, that they really reflect how they see their day going in the best way possible, so that when staff or new team members are in the building, if the care card's up to date and they review it, they have the best opportunity for a successful time that day with that person. And so they might be asked to look at the care card, to give that to the RO. The RO will sit down with the resident and just talk to them about, this is what's on your care card. You see things going differently. This is the way that they should be providing you with that care. I also wanted to remind people that we're hearing about some of the experience that people had and how traumatic it was for them. On YouTube and on our website, there is and I know I sent it out to Mag and Matt, there's a trauma training 7-series podcast done by Dr. Sherry Gibson and Dr. Regina Lewis, specific for long-term care communities. It's for staff, residents, and family members, how to talk about what they went through. There's a lot of anxiety right now about the fall, what might happen again, and having their rights fully restored. I did have a conversation last night with CMS about that, and if there's any other visitation guidance coming out. Because there's some challenges related to the current guidance that we acknowledge. If people are dining together and they're unvaccinated or in a rec program, they can have their masks off. But if someone comes in who's not vaccinated, they have to put their masks on. And we're hearing from the residents who have either chosen to be unvaccinated or have a reason why they can't get vaccinated, that they're feeling a bit targeted because the other residents get really upset if they have to put their masks on and physically distance again. And when we're talking to the nursing homes about that, that's a challenge for them. How do they they have to make them put their masks on. So we did ask CMS if there was a way, they were going to talk to the CDC, could they split the room and have an area for people who wanted to maintain physical distancing, who maybe weren't masked, and wanted to have the opportunity to be at the event, and then another side of the room for the people who were vaccinated and could sit close. He said, we were talking to Evan Schulman, they're going to get us more information. They did not say they would, but they said that, there's a lot that still needs to be explored, but we are hearing from buildings that that's challenging. We're also hearing challenges related to admission, that vaccination status, can that be taken into account regarding admission? Is that discrimination? If it's going to impact the building. So looking at all of those things, and we've asked for some further guidance on that because we know that it's a question that everyone's asking. We want to make sure that we're holding people accountable appropriately and that they're getting the same guidance from us that they'd be getting from health, that they're getting from CMS. We've also heard of bracelets or identifiers being used in order to say if someone is vaccinated or not. We did ask that question yesterday, and the response was a resident can be asked to, if they want to have a way to identify if they're vaccinated, but they can't be required to. And so we think that's really important. We've seen some ways that maybe aren't related to vaccination status, but help staff understand what someone's preference is. I don't know if people have seen the, I think they're called jelly bracelets, or sometimes they have them for different types of events. I have seen where they have red, yellow, and green, and the person can choose to wear the color, and the green is kind of unvaccinated, I'm fine with being around people. Red, it could be someone who's vaccinated but still doesn't want to become in close contact. And it's a way for them to express visually that they want to remain physically distanced. So with resident councils, with resident choice, if they wanted to do that, they could. Again, these are all conversations that we're teasing out, and respecting the fact that people are at different levels of comfort when it comes to, I know even myself, you go into a room with people, we haven't been with people in a long time, and that residents may have choices around that. We're working with resident councils to educate them that just because someone continues to wear a mask or want to be physically distanced, they can't just assume they're not vaccinated, and they shouldn't, again, be targeting anyone in any way. So working with homes to make sure that they have maybe the verbiage to be able to support resident choice, and that all residents feel supported in having the care and services the way they feel best meets their individualized needs. Also, I was doing the Facebook Lives weekly. They've gone to once a month, and their education series now related to this, but we've heard back that not everyone has Facebook, and so that was a challenge for some of the residents. We are moving to a new platform, which will be a podcast, and some of you might actually be asked to join me on that. And so we'll be talking about residents' rights, and residents through the podcast will be able to ask their devices about a right, and it will just tell them. So it might be a right related to privacy, and it'll be a 10 or 15-minute clip, and then there'll be some things that we expand on. So we will let you guys know when that's available. And then lastly is a question maybe to Matt and Mag. We're just wondering if all of the nursing homes are aware of the effective dates of the bills that passed, and just making sure that we're communicating that well. I know we've had a lot of questions related to the technology bill and the paperwork. We've let them know we don't have it developed yet, and that's something we need to work on. So just making sure that they know not to expect that just yet, but that's something we have to still work on and get out. We want to be timely in having that available for them, but I believe that's October. But there's some other things that are July, and just making sure that people understand what those timelines are. One of the big ones was, maybe Nicole can even answer, the P&A. Residents have wanted to know when they're going to see that increase. Is it retro? Should the buildings be giving it to them this month? And we just want to make sure that they're not getting upset with their nursing home if they don't have it, if they shouldn't be giving it till August or something. So just making sure we have the appropriate answers for them on that. And that's it. Thank you.
Thank you, Marie. I'll move on to the DPH COVID update. We have at DPH within this branch, specifically facility licensing and investigations, have resumed survey activities. The survey activity schedule is not as robust as it was pre-COVID, but we will, with each passing month, accelerate the activity, the survey activities. During COVID, there was a suspension from CMS regarding all certified entities. So the state has, and the state specifically, FLIS, facility licensing, has submitted their state plan to CMS regarding how we will catch up. The activity is voluminous. We do have a rigorous schedule to investigate complaints at nursing homes. We also have, and not relevant to this conversation, but a very rigorous schedule to do hospital licensure inspections as well. So there'll be more to come. And again, we'll start to see that activity accelerate as the summer goes on. We do have a large number of new staff also in FLIS, which is impacting the survey schedule. So nursing homes are seeing much larger teams that they're trying to, number one, accommodate the size of the team, but it's essential that the teams be this large because it's a significant integral part of the training process that those new surveyors have on site in survey in facility time. Relative to COVID, while I indicated in our opening remarks that I believe the pandemic is starting to come into our rearview mirror, I don't want to imply or suggest at all that it's off of our radar screen. It's still first and foremost on our radar screen in this branch, but specifically the Healthcare Associated Infections Program. They are continuing to monitor all of the activities that are happening across the healthcare sector, incidents, vaccination rate, reporting. And I thought I would take a few of the statistics off of Dr. Leung's slide deck that she is doing for the nursing homes today, just to share with this group. So an exciting statistic that for me, having been so heavily involved in COVID, and while it's a little moribund, I am excited to report that we have not had any residents pass away in nursing homes for the last 4 weeks related to COVID. And I know that's a hard statistic and it sounds gloom and doom, but it really is a celebratory statistic for us to share, that we are starting to recover. Nursing homes are working very hard. That work continues. Infection control did not stop because our incidence is low. So nursing homes are continuing to execute the same rigor of infection control, utilization of PPE in accordance with policies and procedures, just as they were when we were really in the throes of COVID. So 0 residents have passed away in the last 4 weeks. In the past 14 days, we have had 2 staff cases reported. And these are all important statistics to convey, because in October and November, those numbers were in the hundreds for staff incidents and resident incidents of cases. Nursing homes are still continuing to test. Although the executive order has changed, nursing homes still are being accountable to the CMS guidance document, which outlines how often they need to test in accordance with what's happening in their facility and what's happening broader in the counties. Vivian, Dr. Leung's group is still tracking vaccination rates very, very closely. And the resident vaccination rate in our nursing homes, the average is this reporting period, 89%. And as I'm sure all of you can appreciate, that number moves based on what's happening in the communities. And then the staff vaccination rate, the average is 70%, which we all would like 100%, but 70% is, and I know Mag hears these statistics every time we report off during our industry call. So that's a vast improvement as well. 6 months ago, we were in the high 40 percentile, low 50s. So that is continuing to move. I just want to piggyback on Maireith's comments about staffing. We are looking at staffing. Workforce challenges are emerging. And as a result of that, we are looking at the temporary nurse aid role, which was activated during COVID through an executive order. We did a survey and we know that we have 175 temporary nurse aides that are working in upwards of 55 facilities. And we are working to preserve the integrity of that role. So we have designed a program at DPH, a bridge to that temporary nurse aide to certified nurse aide. And I'm hopeful that our blast facts will be released today. The ABCMS, or the Applicant Background Check Management System, which is our fingerprinting program, or our national, state and national criminal background check for all long-term care facilities, which includes nursing homes. There's been, in the last 6 weeks, an incredible amount of work that's been done in collaboration with the Department of DESPP, the state police. The state police developed a special schedule that was, Maireith, 175 temporary nurse aides. Special schedule was developed with the state police. We are meeting weekly with them. They are providing appointments 5 days a week, 8 a.m. to 4:30 with a 30-minute break every 10 minutes across 11 troops. So there are 528 appointments available every day. We did see that the 3 troops that are closest to urban areas, Bridgeport, Hartford, and Southbury, did book up very quickly. We monitor the number of people that are fingerprinted daily. We monitor the number of available spots there are daily. And during this meeting, we did a survey last week and yesterday. And while we were hopeful for a higher response rate, we got about 30% response rate. We are now calling, excuse me for 1 minute. We were able to generate a script from the computerized program that we have here at DPH and have identified the number of individuals who received a fingerprint authorization form. So we are calling every one of those facilities while this meeting is happening to get the most accurate number of where those facilities are at with the number of authorization forms that are associated with that facility. So for example, Magmarelli Nursing Home may have 10 fingerprint authorization forms for employees associated with it. We are calling Magmarelli Nursing Home to see how many of that 10 will not be fingerprinted by July 20th. So lots of work is being done, and the outcome and results of that work will inform decision-making at a higher level. So I will stop there, and Kate, pass to you if there are any updates that you need to make. And I'm just going to excuse myself for a minute while I get a drink.
Thanks so much, Barbara. I'm just going to call on Mag because I think she has a question perhaps on your remarks.
Yeah, I just wanted to make a couple follow-up sort of questions or comments on a couple things that both Mairead said and also what Barbara said. I think the first thing that Mairead mentioned is so significant to this committee because the staffing issue is critical. The workforce shortage, which we know is affecting everyone, not just healthcare, but it's really critical in our field right now. And nursing homes are making major investments in trying to recruit and retain staff at all levels. As we know, the social working staff needs to be increased just to maintain, to train, to hire and to retain CNAs. Over the last, I would say, particularly over the last 6 months, there's been significant investment. And hopefully that'll be reflected and recognized by the department when we look at the wage increases that people are receiving as effective July 1st, that much of this investment was done prior to July 1st. And it's a real strain. Mairead mentioned the agency staff. I'm surprised people are able to get agency staff because I have heard that even agencies don't have staff available. And when they do, the cost is exorbitant, particularly for RNs. So, you know, it's not an easy fix to go to the agencies right now. And it's a real expensive alternative also. And then really helpful that the state has been very helpful with people in developing their own CNA training program. So we really want to thank the department for that. And hopefully that'll be helpful moving forward also. That used to be a way a lot of people did it, you know, it kind of went out of fashion. And so people were moving back to that. So hopefully that'll be helpful moving forward. But it's an investment. It's an investment of time, you know, it costs the facility money to train people and to train the trainers and all of that. And then on the background check program, we have really been working very hard. And Matt Barrett is away this week, but I can speak on behalf of Matt. I think on this, Matt and I have both been working very hard with our members to try to make sure that all of the 7K workers, the people that were employed during the pandemic who weren't able to get fingerprinted now before the deadline. There is a cost associated with fingerprinting. So not only are we trying to get a lot of people fingerprinted within a short period of time, we're paying for that fingerprinting within a short period of time. So there is a cost per fingerprint. And there's also, because so many people are making an effort, these are people who are now your employees. They're not prospective employees. So if you're reimbursing them for the travel, if you're bringing them to the barracks, and the state police barracks can be far away if you're looking for open spots. So there's a cost to that too. So this is not just a labor intensive practice of trying to or endeavor in trying to get people fingerprinted, but it is costly for the homes also. So I just wanted to bring those up because this is the Financial Advisory Board, and I wanted to make sure that people were aware of the investments that were being made, and the burden that's being placed. So, but working really collaboratively with DPH and really trying to make sure that no one loses their position as a result of not being able to be fingerprinted.
Thanks, Meg. Maraith, would you like to respond to Meg?
Yes, I did want to. So the agency ones that we're hearing, Meg, are companies that have their own agency. I just wanted to put that out there because I understand that there are some communities that have their own agency and they're doing their best to pull from that. And some DNSs are telling us they're not always successful in finding someone, but they are working to do that when needed. And I wanted to mention we are hearing some very creative ideas on how they're getting staff, like going to the schools ahead of time. So it's nice to see sort of that forward thinking. And when you're talking about staffing, you talked about social work. One of the other areas we're hearing is a pinch point is even dietary, which is making meals late. So it's not just the nursing or the hands-on care staff. It's really all of the staff within the building. But I did want to give to Barbara's point about the TNAs and why I asked for the number. Connecticut and the process here is being recognized as a national model as a best practice. And I want to thank everybody, especially DPH, for ensuring that people are fully certified and that we're not cutting any corners and we're making sure that people have that ability to bridge, honoring that they came in, but also making sure that they are meeting all of the standards, because I don't know that that's happening everywhere. And I really applaud and thank DPH for the effort that they've put in there because of how important that is. So I just wanted to point those things out. Thanks.
Thanks so much, Maraith. And I think this is exactly the type of kind of dynamic exchange that we most hope for this group. So really appreciate your comments, Mag. I'll just circle around Barbara and Maraith's remarks with a few comments from DSS perspective. First, I would just like to, on behalf of Commissioner Gifford, who, as you know, is serving dual leadership roles, really just express our thanks again. Looking back on this year, in which there is a legacy of tremendous fatigue, the poignancy of the losses, the huge, unbelievable, relentless need for moving these initiatives, particularly around infection control. I know as we're coming into a new phase and perhaps having a chance to take our breath, take a deep breath and get a little bit of critical distance. It may be actually the first time many of you can get a little space to reflect. So again, just thank you so much for all of this service to Husky Health members, to families. We are strongly in alignment with you on shared goals, we know, and deeply appreciate especially the forums in which there's been a lot of reciprocal information sharing. I would just like to say that that's been hugely instrumental for Nicole and for me, especially surfacing dynamically the relative financial position of homes throughout the crisis, as we all navigated the landscape of the emerging federal assistance, the successive distributions under the CARES Act, but also the terms of the several financial relief packages authorized by Secretary McCaw and Commissioner Gifford, most recently embodied now in a set of terms that are enacted as part of the state budget and detailed in the implementer. So thank you for that. A non-exclusive example, but really important one is I just want to call out David Lawler, really affirmatively raising up observations around occupancy occupancy, around the types of financial constraints and demands around workforce that have continued to challenge the industry. Also, really urging us not to take a unidimensional approach across the state, recognizing that there are definitely variances in experience, especially for the entities that have a continuum of care. And David, that is really just one great example of something that's been tremendously helpful for both Nicole and me. And we strongly encourage folks, please do remain affirmatively in touch in that respect. We carefully consider and are able to elevate, especially to our esteemed OPM colleagues, attention around those types of data points and the sort of evolutionary curve we're on. So thank you very much for that. A few things that I think are important to note. We are still operating under federal public health emergency declaration authority. As I've reported in this forum previously, the Biden administration has indicated that it expects to continue renewing the PHE declaration through calendar year 2021. So at least through the end of December of this year. Why is this important? This is vital because it enables Medicaid programs to continue the disaster authorities under which we're operating, the 1135 waiver, the disaster state plan amendments, and the so-called Appendices K for the community-based side of services. Most notably for nursing homes, I think this is remarkable and in terms of needing continued attention because we can continue the flexibilities that we put in place, particularly around telehealth. There are disaster state plan amendments authorize the continued use of both the video conferencing and the audio only telehealth. I want to recognize policymakers also, as you are aware, enacted both broad legislation around telehealth and a DSS specific bill that has been signed into law by Governor Lamont around both the modalities of telehealth, but also the broad range of practitioners who are authorized to be reimbursed for services. It is not any longer durationally limited. The original enabling legislation for telehealth for DSS, looked forward only a couple of years. So this is just one example of one of the facilitative tools that we hope have been as a benefit, especially to nursing home residents, as we all faced a lot of the serious challenges around infection control. We do plan as of right now to continue that entire portfolio of authority and other flexibilities that we're observing as a program, even while many of Governor Lamont's executive orders are in process of sunsetting this month. So there are some Husky Health authorities that we are dialing back on. And a non-exclusive example of that is the more flexible terms for fills of pharmacy. That's not as relevant for nursing homes because obviously you're providing those benefits. But just take note that the federal public health declaration is really the broad umbrella under which we're operating, even as the emergency authorities are like I said, winding up on the state level. So it's important to note that. From the standpoint of DSS activities right now that are nursing home specific, we, like you, are building in interpretation and tracking for the many, many features of the budget that touch upon nursing homes, not only the enabling language around the transition to acuity-based rates, which I know Nicole will speak to, but also the package of assistance that braids rate increases, health and pension assistance, and other features. Nicole will also be speaking to our plans, our procedural plans for implementation and how that will be conveyed publicly, but we're hard at work on that. We are also at work at the leadership level at DSS across states. Commissioner Gifford and I had the privilege of connecting with a private health policy foundation, the Milbank Memorial Fund, to put together a forum for 10 states to talk about really approaching CMS to press CMS to update and respond with respect to nursing home guidance in federal Medicaid policy and procedure. There's been a lot of flexibilities and interpretive guidance on the home and community-based side, next to no comment from CMS, other than the sort of waiver of some of the rules under blanket waivers. Next to no comment on the Medicaid financing of nursing homes, as we're at this really critical point in history where occupancy is at a historic low. So we had a great session among states, surfaced a lot of questions and recommendations for CMS. We'll be meeting with CMS to really petition for not only the Medicaid folks, but the Medicare folks to get involved in this, because there's essentially a blank space there where we really feel like we need some federal direction and leadership, acknowledging the challenges that are being faced by the industry and the need for potentially a shift in the perspective federally of what is, the kind of premise of nursing home reimbursement, which is focused historically, as you know, a lot on economic efficiency. But at this point, as has occurred on some of the other in some of the other categories of service, consideration of the financial relief piece is something that we really haven't seen CMS comment on. So I do just want to let you know that that is ongoing. We're pressing federally, also taking every opportunity to comment on continuing need from the standpoint of any further distributions of federal funds under the CARES Act Provider Relief Fund. So I think I will wind up there just to say, I know a lot of you have specific questions, particularly about the budget provisions. I want to acknowledge Nicole and her team, our colleagues at OPM, Judy and Sue on this call, and many others, hard at work on broadcasting the features of that, and Nicole will comment further. But we will rely on the same method that we have used previously, including also using the Wednesday forum to talk about that in much greater detail in the near future. So I know a lot of you would like to just buckle those things down, and Mag and Matt have done a great job of surfacing questions on that, and we will do that as readily as we can. So with that said, Barbara, I'd love to turn it back to you.
Thank you, Kate. Next on the agenda is the COVID recovery funding update. And I certainly can piggyback onto Nicole's comments about DPH's contribution or participation in that. But Nicole, perhaps it makes sense to start out with DSS.
Sure. Thank you, Barbara. So just first to kind of take a step back, just to remind folks of what the CRF funding streams were for the COVID recovery. You can, of course, always go to the DSS website because we have still all of the information posted there. I would just like to make note for folks, we tried to clean up the webpage just a little bit. It was getting a little long. So what we did was we moved all of the COVID recovery specific letters and documents and rate increases. You'll now see at the webpage, there's now over on the left-hand side, a line that reads public health emergency. If you click on that, that is now where all of the COVID documents exist. So we just tried to clean it up, keep those documents there, and then keep the rest of the information separate from each other, so it's a little bit easier to identify. So just to reference folks to that new section of our webpage. So just when you reference that section, that is where you will see the list of all the different funding streams that were available to nursing homes in support of COVID recovery relief. And most recently, the most recent supports related to assisting nursing homes with testing through COVID recovery, or excuse me, through COVID testing. There was also the deferral of the phased-in implementation of acuity-based rates. That was part of the package from July 1st to October 1st. There was also supports for ensuring that, let me just bring this up. So there was also supports in there as well, ensuring for shift coaching to monitor infection control, the elimination of the 3 and 4 bedroom arrangements, And what we're doing is we're working closely with the Department of Public Health and ensuring that as homes come in and receive those grant payments for those particular items, then we're working very, very closely with our partners at DPH as they go on site and to ensure that those pieces are actually taking place. So I will defer to Barbara to discuss that piece of it, but we're working very closely in partnership to ensure that the infection preventionist, the shift coaching, the personal protective equipment, et cetera, is all in place. So Barbara?
Thanks, Nicole. So I think the only thing I would reinforce to your comments is related to the synergy. There really is a incredible amount of synergy between, and not only because we share the same commissioner, but because our work is so aligned. And again, this is where I'm going to speak about the quality piece. And the quality piece is directly associated with the funding piece. So we are receiving from DSS, our sister agency, a weekly update on how facilities are doing with the attestations. And during the course of survey activities, we are looking at the implementation of the shift coach. We are looking at, does the facility employ a full-time 35-hour infection preventionist? DPH is actively engaged in the reduction of the 3 and 4 bedrooms. And I know at DSS, Nicole, you and Betsy have seen a fair number of CON requests to take those 3 and 4 bedrooms offline, which is exciting, I think, for all of us. And our Life Safety Code unit will be actively involved in that process. Again, we will remind the providers that when they are doing any of those physical or structural changes to those 3 and 4 bedrooms, DPH does need to be involved in that. For the purposes of infection control compliance, when we do see an issue with a facility having an inability to sustain infection control issues, we are reporting those to DSS, and that is an element or a factor that is considered in continued CRF funding. So it's important not only to DPH, not only to DSS, but it's incredibly important to the sector, the healthcare sector, that you continue to focus lots of your energy on your infection control practices because it does directly align with that funding. We're also doing some supportive activities at DPH that align with the CRF funding elements, in that Dr. Leung's group is meeting with infection preventionists on a regular basis to support the implementation of policies and procedures so that we can see sustained compliance in those areas. So I'll stop there, Nicole, and if there are any questions. I'm not seeing any, so not seeing any questions, we will move on.
I just had one, Barbara. I just had one.
Sorry, Mac. Sorry,
I
Mac,
just wanted to clarify. I think full-time is 32 hours.
32, yeah.
Okay, I just wanted to.
32. I have it wired in my brain. Every single time I say 35, I know it's 32. And I promise I will not make a proposal to change it to 35. My brain's got to change it.
Thanks,
So
Barbara.
thank you, Mag, for that
This is
clarification.
memorialize it in the notes of the meeting. We'll just all consult that.
I say it every single time, and I've got to change the wiring there. Thank you, Mag. So seeing no questions, no further questions, I will move on to survey activities and quality issues. That's the 4th agenda item. As I indicated earlier in our COVID updates, we have started our survey schedule again. We are continuing to do complaints, and it is business back to usual or pre-COVID. But as I indicated, we do need to amp up or accelerate the activity that's based on all the training that we are doing. But to that end, unfortunately, we have seen a few immediate jeopardy situations. And just to take a step back for those of you on the call who may not remember what immediate jeopardy is, it is a situation that occurs in a certified healthcare entity, certified being CMS. So it really is a Center for Medicare, Medicaid Services title or category of care. And it means that the state survey agency has identified a situation that poses an immediate threat to health, life, or safety. And we have seen 3 instances in the last quarter since we last met. 2 of them were related to dietary issues. One was specific to a resident who had choked. The other was related to the dietary tray that was offered. And then the third one was related to CPR or resuscitative efforts for a resident. All 3 have been corrected. The immediate jeopardy situation was abated so that the 23-day termination track was not imposed. And when we identify those situations, DPH does request an immediate action plan that gives the department assurances that the environment of care is safe, that everything that could possibly be done has been implemented to mitigate risk of recurrence. I am hearing nationally, we have not started to experience this, but hearing nationally that state survey agencies are starting to see lots of more citations related to the survey activities. And CMS is looking at that and seeing what any attributes there may be that are contributing to that. Certainly, it could very well be the suspension on survey activities. We have not been in many homes for upwards of 2 years because of how the timing of the survey schedule is. So we, again, at DPH have a very robust survey schedule, looking at other ways to get the surveys done in a reasonable amount of time. And regulators often use the term reasonable, and we cannot, at least I cannot associate a time with that and say that in the next 6 months, we will be all caught up. We are still evaluating and analyzing that, but still investigating complaints, still using our same triage. If anything rises to a high priority, we are out there within 2 days or 10 days, depending on the severity of the issue or the allegation. So that busy activity continues. So if no questions about survey activity, oh, I did write myself a note. One of the things that we were working on since our last meeting was a potential labor action. And this was a very significant event for the industry and particularly for nursing home residents. So fortunately, there were lots of negotiations that were done with labor, with providers, and with the state. So we were able to avert any strike activity. So happy to report off on that as well. So unless there are any questions.
I have a quick question, Barbara.
Thanks, Mag. Go ahead.
Just, wondering if the vigorous and extensive infection control surveys that our state did, as well as the extensive communication the department's developed with the homes, with the weekly calls and, frequent communications, and sort of the collaborative work done with epidemiology and as well as the regulators, whether that really is showing because it has been 2 years, but is that showing that when you're walking into the buildings that people were able to uphold standards throughout the building, not just on infection control because of this, I don't want people on the call to think that DPH just hasn't been in the buildings for 2 years, but actually I would say your presence within the nursing homes has actually been enhanced over the last 2 years, and the work that you've done with nursing homes. So wondering if in our state that's showed to be a positive.
So I think that's to be determined. But to your point, Mag, we did conduct over 3,000 focused infection control surveys in nursing homes, and that does include assisted living facilities, but the bulk of that was in nursing homes. The survey was very different than our typical certification or licensure survey in that it was collaborative. I want to hope that that collaboration is going to contribute to any outcomes that we could potentially have as we move forward with the certification surveys. So thank you for pointing that out. So if there are no other questions, and Melissa, I don't see any, I will move on to receiverships, closures, and bankruptcies, and I'll pass that to my colleague, Nicole.
Thank you, Barbara. So since we last met, we still have one facility that is in receivership. We have had one closure and we have no bankruptcies. So since we last reported from last quarter, since we last met, that's our current status. And I would note that the one closure was a building that had been vacant for quite a bit. So this wasn't a closure in the sense where there was residents that needed to be noticed and moved, etc. So this had been a building that was empty since January. So this was just kind of the official closure of that particular license. So I just want to kind of preface that. If there are any questions, Barbara, is it okay if I jump to case mix unless anybody has any questions?
Mag, your hand is up. Is that a legacy hand or?
Yes, it must be. I thought I lowered it. I'm sorry. You can.
Thank you. Please go ahead, Nicole.
Sure. Great. Thank you, Barbara. So just touching back upon what Kate had mentioned earlier, the case mix Acuity, I'd like to just kind of start today's conversation around this because I'm sure folks are going to have lots of questions. Just first prefacing back to the April 13th letter that was released from the Department of Social Services and OPM, that joint letter. And again, that is posted on our webpage, and it's under the public health emergency section that we just created to put all those particular documents there in one location. And folks may recall in that letter that there was a section about acuity-based reimbursements where it was messaged out that the implementation of Acuity would be shifted. Originally was supposed to launch July 1st of this year, but that it was going to shift to October 1st of 2021. So what does that mean? Well, as we saw what came through in the implementer and in the state budget, the agency DSS, we have been tasked with putting forward what Acuity looks like, the rates, how the homes will be impacted. So we are planning on doing quite a bit of stakeholdering through this summer leading up to October. We're going to be meeting with homes, meeting with the industry. We'll hopefully be able to utilize the Wednesday industry calls that have been kind of a great forum for us to be able to touch base with everybody at once. So we'll be able to start kind of messaging and working through that leading up to October 1st, where we plan on being able to start showing homes individual impact of what Acuity would look like. And then after the October 1st date, we'll continue to work with homes, continue to have back and forth, ongoing discussions. We have always committed to kind of being open and transparent and inviting feedback and working closely with the homes on what Acuity will look like and how is that's to be structured, with the aim of launching, as per listed in the state budget, of launching Acuity rates coming up for July 1st of 2022. So I know it was a little bit confusing in the implementer, but so the actual launch of what the reimbursement structure would not be until July of next year, but on October 1st is when we're going to start to message out what impact actually looks like and start working with homes directly. And again, so all that information, we're going to utilize the DSS webpage to be able, we do have an Acuity page built. It hasn't been updated for some time because obviously we've all been kind of focused on COVID and dealing with the public health emergency. But now that we have new direction under this state budget that just passed, we're going to revive the webpage, start to freshen it up, get some more information out there, start having our stakeholder meetings. I know, Mag, we meet regularly every week with you and Matt, and this has really been part of our ongoing discussions to get these meetings back up and running. So I think probably you guys probably have more questions than anything. So I guess I kind of open it up to questions because I'm sure folks have I can see Mag smiling. I know you've got questions, Mag.
I just, you know, and we're looking forward to working with you and on the quality measure piece of the Acuity based system. Also, I think it's important for us to sort of look at the timeline as an advisory group, that in October, people are going to start to see the impact of the Acuity rates on their reimbursement. At the same time, everyone now has 9 months of a temporary rate increase as they're trying to rebuild census. There's actually a new CON process if you want to reduce rate beds, and people are to use this 9 months to sort of plan ahead as to whether or not after the 9 months with the temporary rate increase, whether they can continue, whether successfully financially, whether they'll be able to rebuild census, do they need to downsize their nursing home, and can they do it in an efficient model? So all of these things are coming together. And I think it's important for the sector to understand all of the different dynamics, and particularly the CON process. The other piece that's in play now is people who are going to make changes to reduce beds or to do what they're going to do are going to make physical changes probably. And as Barbara said, they'll need to go through the DPH process of getting that approved. They'll need to finance changes. And so, you know, right now is a good time for financing. So time may be of the essence for people to make some changes. And so we need to keep that sort of in our mind in the whole time, the timeline. And then I think another piece that Kate mentioned that maybe we can also keep talking about is whether or not CMS can make some changes to how the rates are developed. And if we can get that and what that's going to mean to people. And I think that the providers need to have all of this in mind as they're really actively planning over these next 9 months as to what the future is going to be for their particular site. So it's a multifaceted piece. The CON process is so important to that. And I think providers need to be aware of this batching and the deadlines to get their plans in if they're thinking of when they're going to make these changes. So I think that needs to be sort of in play too when we inform the providers of the rate, you know, when we get the answers to the frequently asked question, you know, for the rate increases, also to make sure everybody understands the CON process and the whole timeline, because this could be a really very important 9 months for the sector. And we just had to make sure that everybody's engaged, understands, and is actively working to make the 9 months work for them and for everyone else.
Yeah, no, Mag, that's an excellent point. And thank you for bringing up the FAQ. So just so folks are aware, you know, there were multiple buckets of money, and I think Mag just referenced a couple of them. So over the next coming 9 months, homes will see increases. There's going to be a 10% increase, a 4.5% increase. You know, there was money being put forward to help support homes. They're looking at the CON process, for example, as Mag mentioned. So there's in the state budget, there's multiple different buckets of money, and all of it is designed to help support homes moving forward and the transition through Acuity. So you're right, Mag, there's multiple different moving pieces. So how does a home plan when there's all this going on? So that's why we're trying to work very closely with our partners at OPM to develop an FAQ. It'll, I'm sure, just be one of many FAQs that we put out. Just to really start to outline the different information that was put through the state budget, what's available to homes, how that money will be put into the rate, pushed forward to the homes, and to hopefully help the homes to be able to start to plan and kind of make those long-term decisions on what they need to do. So we are actively working on an FAQ. We have it currently internal with DSS, so it needs to go through our process, and then we need to ship it over to OPM for our partners at OPM to take a look at it, just to make sure that it aligns with the expectation in the state budget. So once we have that all lined up, what we're going to do is go ahead and post that to our website, message it out to the industry, have a stakeholder meeting so everybody can kind of come on board, and it'll be the first of many that we'll be doing to start to get that information out there so homes can make those long-term decisions.
That'd be great. And as you know, both Max Association and Leading Age of Connecticut would be happy to work with you to put on whatever kind of programs, get that information out to everyone. And like I said, and I think the CON process also, you know, people really need to be informed of that too, to just help them plan. It's time.
Yes, absolutely. The volume of CONs has dramatically increased, I think, in light of COVID. You know, just to kind of give you an idea of the increase, typically in an average year, we'll see maybe 5 to 12 CONs. We're now looking at 100. So we have about 100 CONs that have come in, and it's a wide range of certificate of need applications. It's everything from, you know, maybe just, you know, doing addressing the 3 and 4 bedrooms. So homes are addressing those arrangements in a variety of different ways. To some homes are going as far as looking at, well, maybe I'd like to add a different service or a different component to my building. So there's quite a wide range of applications and interest that we've received, but the volume for the CONs, yes, has dramatically increased. So I completely agree with you that that's going to be an important piece as we have our stakeholder meetings, and adding that to the FAQ. We do have a CON webpage, a dedicated CON webpage. So we do have some information posted about the batch application process. That batch process was put forward because we know we have such a big volume of CONs, and that we want to look at the CONs that in particular deal with bed delicensures to ensure that we're looking at a geographic area. So that was the intent behind doing the batch process, so that we're not shorting an area of the state. So that if we have a home that comes in, we're kind of looking at that entire area, so that we make sure that we don't short a particular county or an area. When we look at the geographic region, we're looking at a 15-mile radius. So that's why we're doing the batch process. So that was the thought behind that. But there is additional information out there, and we'll continue to include that as we have our meetings.
One thing that came up in a discussion was that with the new batching process, as people are planning, the results of the first batch are going to impact people's planning in the second batch, right? So if you're thinking and you're planning, and then suddenly you realize that 2 or 3 buildings in your 15-mile radius have made CON changes, you know, reduced beds, added services, done something that may impact what you were thinking of doing, you know, it might change your demand, the demand impact in your market. So just something to think about. How are we going to make people aware of what's actually being planned in the area that might impact their planning? And, you know, I know that, so I suppose they'll be posted on maybe on the CON website, what CONs have been granted. I don't know how we want to do that, but just something to think about, because, you know, what one person does is going to impact what the other person can do or can't do. And so we can talk about that also moving forward.
No, absolutely. I think that's actually an excellent idea. You're right. But there's some type of way that we could put out, like, you know, what it's looking like, what the shift and what the changes are looking like. And I agree. Like, so let's continue in our weekly conversations. Like, let's continue to talk about that, and maybe we can develop some type, anything from a simple spreadsheet to, you know, we can talk about what that looks like. But I agree, we should put out there in some way what those changes over time are looking like, so that everybody can understand how the industry is shifting.
Thanks, Nicole.
Any other discussion, comments, questions? So next on our agenda is our legislative updates. And we keep this one very open. to have discussions with, I know Maurice, you had mentioned, you had started discussion about legislation and effective dates implementation. We at DPH also are sorting through our effective dates, July, October, and we even have some for next year. So lots of work is still being done to see where legislation has landed. Fortunately, we have Bree and Jill at DPH, so we are very, very fortunate. I don't know if there is anything specific, questions, concerns, issues. I know it was an interesting legislative session, not being able to do the face-to-face, but I think we collectively got through it and got through it very successfully. Maurice, Kate, Nicole, Mag, any comments about legislation that we need to pursue further? I still think it's a little bit early at DPH to talk about our rollout, but we have lots of work ahead of us.
So Barbara, I think that was incredibly well said. I would just like to acknowledge both that there's a lot of nursing home specific legislation. Maritha and Barbara has touched on those pieces. I think we're all very cued to those. Also of interest to all of us is that the legislature has given us some opportunities to expand our coverage, not only under Medicaid and CHIP, but also for some folks whose immigration status does not presently qualify them for benefits. So if I may just briefly touch upon an overview of that, we have a lot more detailed information that we are very happy to distribute through Melissa, because I know some of this will be important from a reference standpoint, but this is essentially a package of eligibility options that has been put together by the legislature working with the administration that is being rolled out successively. The first stage is effective, was effective, I should say, July 1st. And that is a new endeavor called Covered Connecticut, under which the state is using state resources to wrap around individuals in identified income ranges who are buying silver plans on the Access Health marketplace, to wrap around them to essentially bring their cost sharing obligations for premiums and out-of-pocket expenses down to zero. That's a combination of the historical subsidies for those plans and then the enhanced subsidies under the American Rescue Plan, now plus these state resources. So the whole aim is to make buying insurance on the exchange more affordable. Why is this of interest to the nursing home industry? Both from the standpoint of more folks having insurance coverage who may be resident in nursing facilities, but also for your workforce. So I think it's extremely important to note that this does reflect a new affordable option for folks who may not have been able to qualify historically for Husky Health, and really have been, essentially faced the barriers of the cost sharing on the exchange. So that's the active now. Access Health is doing outreach and enrolling people, and again, we'll forward some summary material through Melissa, but this is a very, very important, significant event. Also, we will be expanding Medicaid and CHIP in a number of ways. Just so you are on notice, going to be expanding pregnancy coverage to cover a longer period, prenatal and postnatal care for some women who are undocumented, and then also covering some children whose immigration status does not currently qualify them for Medicaid and CHIP. Overall, I think a really terrific piece for you to be aware of, again, potentially around workforce healthcare coverage. This is helping to knit together some options to continue to reduce Connecticut's already low uninsured rate. But I know that healthcare coverage was a major feature of the labor discussions that homes who are in negotiations contended with. And so I think it's really important that you're literate around the new options that are available. So let me stop there. Like I said, I think it's going to be easiest to look at the materials that we can forward through Melissa as a reference source, but certainly welcome any questions that you may have. I'll just say also, we were very fortunate to also get some new covered services in Medicaid. We're going to be covering services of licensed acupuncturists. And I'll just clarify that licensed acupuncturists are folks who've attended a 3-year program and then been licensed through the Department of Public Health, as opposed to physicians who receive training in acupuncture. We're covering acupuncturists and also chiropractors. We had a limited pilot some years ago to cover chiropractic, but this is represents 2 new interventions for pain for folks, particularly as the aim around this. So I think that's notable. Also, we will be covering violence prevention and trauma-informed interventions for folks, particularly around with the aim of supporting folks who may have been involved in incidents of gun violence. And this can be extraordinarily traumatic. So again, I think this is a really important expansion of the already extensive portfolio of Husky Health Services. Really excited about all 3 of those. And I think the final piece that I want to point to of interest to nursing homes is we are this close to getting final approval for the state's CHESS initiative. This is an amazing opportunity we have to braid Medicaid coverage of supportive housing services with purpose appropriated vouchers, housing vouchers from the Department of Housing. We've been hard at work on this. It's been a really intensive stakeholdering process with among the Departments of Human Services, partnering with OPM, but also private partners, including the Corporation for Supportive Housing, the Family Partnership, and the Connecticut Housing Finance Authority, among others, all toward the end of providing new options for people who have traditionally not had enough support to remain stable in housing in the community, have experienced homelessness. As you know, those folks can tend to go to the emergency room and be admitted for an acute need in a hospital and then discharged to SNF care, ultimately be determined not to meet level of care. And then there's very difficult circumstances for many of you homes in the discharge process and locating suitable resources to connect someone so that they're not just being discharged again into homelessness. We had raised legislation this year. Legal Services was the main proponent that was not enacted, but would have tried to limit the scenarios under which nursing homes could have discharged such folks. We view CHESS as a direct enabling tool in helping to keep these people stably housed and supported using, as I said, both Medicaid dollars and the housing subsidies. We have had very good news on the most recent exchange from CMS, and it's really kind of a matter of the last nuts and bolts on that. So we're still hoping there may be a chance for an August 1 start date on that. So I did want to make sure you were aware of that, not directly relevant to your purposes on a day-to-day, but certainly for the discharge process for complex needs folks. I think it's important to know. So Barbara, thanks so much, and I'll turn it back to you. I'm sure Mairead has comments also on legislation.
So thank you, Kate. And Mairead, I just want to brag on you for a minute. We did have some legislation this past session that at a state level addressed our essential support person. But Mairead was also working with a contingency in Washington. So Mairead was a key integral person involved in federal legislation that is currently in place. So I will pass it over to Mairead to talk a little bit about that. And then I can finish up with some of the DPH or FLIS, specifically FLIS issues. But most of our issues this session were technical revisions. So I will pass it to you, Mairead.
Thank you, Barbara. And actually thank everybody for their support here in getting to the heart of the essential caregiver Piece was hard, right? Using what guidance was in place federally. I think everyone acknowledged the need that residents had to have those personal connections with people outside of the nursing home. However, being able to do that within the federal guidance was really challenging. But I do appreciate everyone coming to the table and working on that. And we used a lot of what we learned and what we heard back from DPH and the associations as challenges to really work on the federal language. So there is a pending bill. It's HB 3733. It is a bipartisan bill. One of the original co-signers and sponsors is Congressman Larson. So we have done a big push federally. I was in DC about 2 weeks ago to work on this, and we're still having a lot of meetings with the Ways and Means Committee regarding this bill. So if people want to support it, please reach out. I think my main goal is to ensure that if we do have a situation like this again, that there's guidance in place so that there aren't so many questions, so that buildings know what to expect, residents know what to expect, and that it honors the fact that we all need those connections, but we also need the ability to safeguard and provide those infection control measures. Kate, I had my hand up also because for you, I didn't know if you had the opportunity to talk at all about the changes within MFP and some of the federal changes there related to the timelines and what buildings should be expecting, because I know that's something we're going to be helping to make sure that they're aware of and support residents around the new timeframe changes.
Yeah, Marie, thank you so much. I apologize. I feel like it would be best if I asked Dawn to provide a written update on that. I haven't had a chance to circle around with her, but I appreciate the suggestion and I agree. We definitely want to underscore that.
Got it. And I think for us, one of the main components of the changes that we're really happy to hear. Connecticut has always had an MFP program that was going to continue, but that wasn't the case for all states and for all people. So although it doesn't really change a lot here in that way, I think it just acknowledges that piece. Also, the change from 90 days in order to transition out to 60 days. So I think it'd be really helpful if we could get sort of a briefing on that from Dawn so that when we're asking about it in the communities that we know that the industry is aware of that.
Yeah, Marie, I'll just circle around on that and say, in addition to those features, congressional Democrats have raised a package of legislation around long-term services and supports, predominantly focused on the HEBS piece, but that does propose that MFP finally be made permanent. It's been a demonstration program for now many, many years, longer than is typical. So that's also something that's important to note in terms of just permanency of funding and expectations.
Thank you. And related to the other bills, as we talked about earlier, and Barbara pointed out, so we know that there are timelines. We want to make sure that we're meeting those timelines and having time to collaborate with our sister agencies as well as the industry to ensure that things align well and that we're all on the same page. So I know we've had calls from residents, family members, and discussions with some of the buildings and just making sure people know that we're working on it, but some of those things aren't exactly in place yet. One of the things we're getting the most questions related to is the technology piece. And so making sure that we move forward on that. And we know that that's something people have been waiting for, and we'll get that done as soon as possible. And that's it.
So I don't think I have too much to add other than what Marie and Kate have already said, that there'll be lots of, again, collaboration between the agencies regarding particularly the essential support person and family caregivers, because those will be issues that we look at on survey. We will be reaching out to the industry again as we do further development about, and again, what policies and procedures that we will be implementing at DPH. So as we develop those and any impact that there may be to the sector, we will certainly share that. And I just wanted to go back to a comment that Nicole had mentioned that using the industry calls as a vehicle for communication. We are going back to our quarterly calls, but we can always convene a call at any time because we do have the platform at DPH. So we stand ready at DPH to help support that, Nicole, when we do need to do any webinars with the industry.
Thank you, Barbara. Thank you. Greatly appreciate that.
Any questions, comments, discussion about 2021 legislative session? Mag?
Well, you know I was going to have to say something. But we're looking forward to working with Mairead on the video bill, and I know Mairead's has the option of creating consent forms and can work and will work with CHCF and Leading Age. So we're looking forward to that. We're already trying to help, as you asked Mairead before, we've informed our members, and I know Matt's informed his members of the various pieces of legislation that passed and the timelines and the effective dates. You know, and things get confused. You can see why residents and families and even nursing homes can get confused as reports come out. The governor just signed the big omnibus bill. And so we have a lot of interpretive questions on that one also, things we tried to work out before it was passed, things we think might be legislative intent. So we'll be working with DPH on those to make sure a lot of that goes into effect October 1st also, but to make sure that people are in compliance. People are very anxious. They want to be in compliance. They want to understand how DPH is going to interpret it. And also the 6666 bill, the technical changes, you know, that's a very long bill. There's a few sections that affect us, and there were just some questions on that. So we're you know, Matt and I will be looking forward to working with you to help make sure that everybody understands and is clear on what the expectations are for all of that legislation. The other federal piece I just wanted to bring up, and because again, this is the Financial Advisory Committee, and one of the big pieces, one of the big waivers that in fact affected financing, not only for the nursing homes and the hospitals, but also for residents, people on Medicare, was the 3-day stay waiver piece. You know, so many times residents are caught with a bill they didn't expect because they got to the nursing home and they were only in observation. So just, you know, wondering, Kate, what your perspective is on that, on the future of that. It's still in effect. There is no requirement for 3-day stay to have your if you need rehab to be covered in the nursing home. And do you know from the perspective from other states or any conversations you're having if that has had a positive impact overall?
Absolutely. So I think universally so, and National Association of Medicaid Directors has definitely raised this up as an advocacy issue in terms of permanency. We had previously done that at several intervals of time, most notably when CMS was offering opportunities for states to do Medicare, Medicaid integration initiatives. And that was one of the procedural rules that we identified as a major problem for folks, exactly as you said. I defer to Barbara if she's heard anything different, but my understanding is that so long as we have a federal PHE declaration, the blanket waivers continue without any interruption. But that question around permanency, I do think it kind of requires all hands on deck at the federal level. So we are arguing for that. I think if the national parent organizations can also do the same, I think it would be extremely helpful, and particularly with the new Administrator Brooks LaSure, I think at that level would draw attention to it. And I know she's very eager to hear from stakeholders across the country.
Great, thank you.
And Meg, I've been talking to and starting to meet with Judy Stein, Medicare Advocacy. So I think, you know, being a state where we're fortunate enough to have them right here with us, that maybe there's something we can do collaboratively to talk about the impact that we've seen homes, successes for residents in care and treatment, and work with Medicare Advocacy to ensure that they have the information they need to call for this to continue.
Great, good idea.
Any other questions, discussion, comments? Any other business that we need to discuss? Any other questions? Is there anything that we've missed on the agenda item that we have 27 minutes that we can discuss? Hearing,
We're back on the, I keep bringing it back to that, I don't want people to think I'm cold, just talking about finances, but it's the Finance Advisory Committee.
yes.
They're currently doing the audits of the 2018 cost reports, I believe, right? Was that correct, Jonathan? Did I state the dates right? And so it would be very helpful, I think, to get some feedback if they're finding common threads of issue, if there's any issues that are being found in those desk audits, because I think that impacts, potentially, I believe that included a wage enhancement. Nicole, correct me if I'm wrong. So it'd be helpful to us to be able to communicate that to people if if they're finding any common issues or concerns.
Sure, no, absolutely, Mag. Yeah, I mean, just so folks understand the process, so when we do the desk audits, through our contractor who supports us in this, Myers and Stauffer, they work closely with the homes. If something pops up, homes are given the opportunity to kind of clarify, correct, etc. There's a bit of back and forth. And then if there is a finding that happens, then homes are noticed of that particular finding, and from there, we don't generally message out individual findings because it's between the home and the state. But yes, if there's like common threads, because there was a wage increased in 18 because there was that piece in there, what we can do is I can reach out to Myers and Stauffer and see if there is a common thread, if there is something generally that's being seen, and we can message out on that.
Sure, because we don't want to see problems, and we don't see problems repeated, and we want to make sure we clarify and correct things if we can be of assistance in trying to clarify things. So thank you.
Sure. Mm-hmm.
Any other comments, questions? I just want to, as I reflect back on the last 15 months, just really express my gratitude to all of our stakeholders, including the healthcare sector and our providers, on the incredible work that collectively we did do. And while we did have many losses, we had many lives that were saved. So again, that was done collectively with all of our incredible collaboration. So grateful for that. And then I will pass over to Kate, Nicole, and Maraith for any closing comments.
I will just say here, we are tremendously indebted for the partnership and also, like I said, the active dialogue. So definitely pass to Maraith.
Exactly. And I really appreciate Matt, and you can tell Matt this for me, Mag. I do think at a state level, we have good communication. We're situated in a way that we see each other a lot. But in having conversations with other states, they don't all have the ability to come to the table, see things differently, but really dialogue with their associations. And we're going to see things differently, right? We're going to have different ideas and different approaches. It doesn't mean we always have to pit against each other, because that doesn't get anybody anywhere. But I think having you guys really be able to hear what I'm representing from residents and family members, bringing it back here, working collaboratively with all of our peers and other state agencies, I think really did benefit the community at large. And I've said it to the governor's office and the state agencies, but it allowed me to be able to appropriately communicate with residents and family members about what to expect, why things were happening, and keep them fully informed. So I really do appreciate that. And even though sometimes I have to bring up tough topics and hard things and maybe take a different approach, it's not because I don't respect what people are trying to do, but that there might be different points to that. So I did want to thank you all for that, and to the other agencies for their partnership.
Absolutely. If I could just comment for a minute, we appreciate that, Maureen, and we appreciate everything you've done through this entire time and the communication that you have had with us. And I just want to, again, agree with Barbara. Thank you to everyone on this call for all the help, and support and collaboration throughout these last 15 months. So thank you.
Any other comments? If none, Melissa, I'm going to pass over to you. And again, I have to acknowledge, grateful for all that you do just to put these meetings together. Thank you.
No problem. So we just need a quick motion to adjourn.
So moved?
Thank you, Mag. Second?
I'll second.
Thank you. All in favor?
Aye.
Aye.
Okay, we are adjourned. Thank you.
Thank you, Melissa. Thank you all. Stay well.